I'm Dr. Ripple Shah. Did my MBBS followed by pathology, MD pathology, followed by DNB in transfusion medicine way back in 2005. I was the first candidate to enroll for DNB in transfusion medicine, and at that time, transfusion medicine was considered as a part of pathology. Very few, we can name it like PGI and SGPGI. They were the only two institutes where we were having MD in transfusion medicine. And I was the first DNB in transfusion medicine. That is the National Board of Examination. I enrolled for DNB in transfusion medicine. It was conducted in Prathma Blood Center. So after that, I worked with Prathma for 8 years. And after that, worked with State Transfusion Council and taking care of Gujarat's blood bank, all blood banks of Gujarat. Then worked with Red Cross Ahmedabad, and now since last 4 years working with Prathma Blood Center Ahmedabad. It is a standalone blood center functioning in the field of transfusion medicine in last 20 years. And we are into blood component separation, stem cell harvest, leukophoresis, dendritic cell therapy, granulocytophoresis, platelet pheresis, plasma exchanges, and titer, and many more things related to transfusion medicine. So in routine practice, day-to-day activity, we are usually receiving samples from patients all over Ahmedabad and maybe the nearby places of Ahmedabad. Whenever the patient needs in blood component, the clinician used to send a request and sample to Prathma. And as a routine protocol, we are doing Coombs cross match, and if compatible unit is found, we issue the blood unit for the patient. So suddenly in 2020, I received a case where the patient was from Rajkot city. Patient was a 65-year male patient. When he was having complaint of breathlessness on exertion, and an angiograph it was showed as a 3 artery block, and doctor suggested to undergo CABG. And as a routine protocol, the clinician has asked for 2 units of red sulfur to keep ready in the local blood bank of Rajkot city. There they tried with multiple units in Rajkot city, but the same blood bank could not find any compatible unit. And when there is a no compatible unit, they cannot transfuse the patient, and surgery got delayed. Then the patient was referred to other blood bank of Rajkot, likewise to many blood centers of Gujarat. So we were the 7th blood center in Gujarat where the patient was referred. Because patient was supposed to undergo CABG, and without blood unit availability, patient was not being operated. And there was a concern for the clinician of Ahmedabad, and that is why they referred the patient to hematologist, because he doubted something. There is some abnormality in blood is there, which is giving incompatible reactions, because patient was in ABO-RH, patient was of AB positive blood group, A1B to be very precise. So fortunately with A1 blood group, we can try with A, B, O, AB, every blood group. And mostly all blood centers tried with multiple, in hundreds of units with each center. When patient referred to us, we also tried the same initially routine method, and it was found it is not giving compatible reaction with so many units. Then we thought there is truly something abnormality is there in the patient blood circulation, red cells or antibody, something is there. Patient has got some antigen or something is missing which has produced antibody, because the antigen whichever is missing, that can lead to the development of reciprocal antibody if there is a exposure or a naturally occurring. There are 2 ways to have antibody. One is naturally occurring, which can be any reason, maybe food particle, maybe unknown etiology. So, or that is a immune mediated antibody, that is allo antibody, and maybe because of transfusion, pregnancy, abortion. But this is the male case, no previous history of transfusion. So we thought there may be some naturally occurring antibody or some very rare blood group which is not possible to get a cross-match compatible unit. So firstly, we tried with the family history. We take a detailed history of the patient's son, daughter, and wife. In that, when we did a cross-matching, the same result was there. Son was B positive, daughter was also B positive, and the both were giving incompatible reaction. Then we just slightly expanded our research or expanded further grouping with the help of his brother and sister. His brother was again in a Rajkot, so we managed to get his blood sample. And fortunately, we got the compatible unit with the brother's sample. So now it is, but sister was not giving compatible reaction. So now it was a good hope that there is something which there in the family itself. Both the brothers are having the same kind of reaction, but fortunately, the patient himself's blood is not matched with other blood units, but his brother, which blood was compatible with this patient sample, the brother himself is getting compatible unit with other donors. So that is again proving a theory that there is some antibody developed in the patient circulation, which was not there in the brother's circulation. So that is why brother is getting compatible reaction unit compatible, because patient brother doesn't have that strong antibody in that circulation, but the same antigen is missing in the brother circulation, which the patient already has the antibody developed. Till that time we were not having any reason, any idea ki which kind of blood group. So we thought of initially common blood group like NTH, Bombay blood group. We thought of Indian blood group system. So that was the scope of my blood center. But then beyond that, I was not having a rare and cells panel. So then we approached Dr. Sanmukh Joshi. He is working with Surat. He's a senior scientist, and he worked with Bombay Hospital way back in 1915 when the Bombay Blood Group, he was one of the members in Bombay Blood Group investigation committee. So we approached him, what could be the possible reason for this. So he suggested us to contact the New York Blood Center. So that was the peak time of COVID. 2020 was the peak time for COVID period also. So we were getting difficulty in getting sample from Rajkot to New York. There was flights were not so many options available. So finally, but we could manage to send a sample. New York Blood Center was quite cooperative enough to give us permission ki please send us a sample. We won't charge anything. We'll do some investigation on your patient sample. They also thought that there is some missing antigen is there in the patient circulation, which has produced antibody. So we couriered the samples of son, daughter, wife, patient himself, and brother, sister. So all these samples we sent it to New York Blood Center. They did a lot of research, lot of studies. They tried with by that time it was decided that there is some antigen is missing, and that has produced some antibody. So that is known as antibody against high frequency antigen. So that high frequency antigen is most of the population has got that antigen, but that this person might be missing with that antigen, and that has led to development of yellow antibody. That has led to development of some antibody, and that antibody is giving the reaction with most of the cells population. So then they tried with the high frequency antigen. They have a good library of rare cells also. They cut down the incidence rate, then they reduce the bring it down to less than 0.01%. So they selected few samples, and then they did a analysis of this sample for missing antibody, which is the missing antigen is there. So then they thought they have some EMM panels or preserved samples also, because in the world till now this is the 10th patient who has got this antigen missing. Most of the population, that is 99.999, only 10 people in the world are lacking this antigen. So, but fortunately they are having some of the samples, because previously also they did some of the research, and they had same kind of samples, red cell preserved frozen samples are there. The New York Blood Center took the samples from the library, their own library, and then they matched the thing. So they found that this could be of EMM specificity. Till now, we were not sure of EMM, whether it is EMM negative system. So New York Blood Center did then DNA analysis. They extracted DNA from all the samples what we have provided to them. This was the first Indian case where we found such kind of thing. So they extracted DNA, they did the analysis, and ultimately they found there is a missing exons. Then it is they found that this is a two base with missing this, and that has led to development of antibody, and this could be of EMM. That is how they reach. And when they checked with this 9 samples which they were having in their library, then they reached to a conclusion that this could be an EMM negative blood patient. Though most of us are EMM positive, so that is till now we are in the EMM was considered as a high frequency antigen series. It was not named as antigen or blood group system. We are having more than 40 known blood group system, but EMM was not recognized as a blood group system. There is we have a International Society of Blood Transfusion, and they have a committee on the this grouping, what we call this as a nomenclature committee of ISPT. They met, we present, on behalf of us, Dr. Len presented the case in front of them. They went this whole genotyping structure, the family, the all 10 samples, result data, everything. And then they decided that this could be the labeled as a blood group system, EMM negative blood group system. And then finally in the end of 2020, they declared this is a EMM negative blood group system. And ISPT nomenclature committee gave them a numerical number, ISPT 042. This is a 42nd blood group system, which is known as EMM negative blood group system. Basically, EMM is first observed in way back in 1973. If I'll give you history, back in 1973, first it was described that there is something like EMM is there. If you go through transfusion medicine literature books, we only find 2 line of sentence currently that EMM is a very high frequency antigen. It is 901 code is there, and which is very high frequency antigen system. That's it. We don't have anything written in our textbooks also. But if we go with the history part, we first observed in 1973 and then reported, which was reported in 1987. Fortunately, this antigen only out of 9, 1 patient was having hemolytic transfusion reaction. Otherwise, most of the specificity is not identified also, but most of them out of 10 cases, almost all are IgG type of antibody reacting at 37 degrees centigrade. And this EMM is located in GPI linked protein. So the patients who has a PNH kind of thing, they are also lacking the GPI protein. So this EMM doesn't react with high RBC, with of the patient of PNH type 3. So that is correlation. Later on, it found established that EMM is linked to the GPI protein system. But still, this is a very primitive stage to label also. Whether it is GPI protein linked or something like that, it needs more evaluation, more sample size. Way back, again come to history. If I'll come to history part, then the first patient was from a French person from Madagascar. That was the person having EMM negative system group. The second was the white African person. It was find in a white African person. One Pakistani is also there. There are 2 brothers from the French Canadian family. both are having, like our patients, this both brothers are also having uh, EMM negative blood group, and one of the patient has developed hemolytic transfusion reaction, and that is how, this is the only case where we can find a hemolytic transfusion reaction. So we don't know whether it lead to hemolytic transfusion reaction, HDFN also. It is not yet established fact ki whether EMM negative patient can develop the transfusion reaction or HDFN. Then there was a North African sisters also, two sisters also there. They are also found having EMM negative blood group system. Two males from, they are not brothers, but two males from USA also having same kind of blood group system. And the last patient was from Japan, that was also having EMM. These are the 10 patients in the world, and our patient was the first Indian Gujarati patient who is having EMM negative blood. But at that time we were not having any blood group available. Only blood group available was his brother's blood group. So we thought of, we started erythropoietin treatment by that time, because this was taking too long for us to decide what to do. And without any blood unit availability, it was not possible to operate that patient. So we thought of leapfrog technique for blood preservation. And second thing, we thought of keeping his brother ready for blood donation. And at the time of operation or pre-procedure, we would harvest the unit. But we started erythropoietin also by that time. And fortunately, the patient with erythropoietin response, I don't know what kind of response it gave us, and patient was suddenly having better feeling, and patient family was also little bit afraid to start the bypass, because in case of emergency, if patient needs more than 2 units or 3 units, how we can manage, that was also a case query, and that was also a risk factor. So the patient doesn't want to operate now, and we just managed the patient with erythropoietin, and patient was maintaining his hemoglobin somewhere around 13, 14 till the last I had a contact. Unfortunately, we lost that patient, not because of cardiac problems, because of his age-related issues. We lost that patient in this March only. But by till this March, patient was very well maintained, healthy. We were in continuous touch, but patient was feeling better, so he was not ready to operate now. I don't want to operate. When we just to give you brief history about serological test, what we did is when we received blood sample for grouping and cross matching, we did blood group. As I've already told, it was A1B. We tried with all the units, which was incompatible. We tried with all 40 known antigen phenotypes, and we checked patient phenotype also. After amongst all 40 blood group, patient was negative for capital E, capital K, KPA, JSA, JKB, Lutran, Dombock, Lewis, everything we tried. But over this doesn't help us, because this was something new. And with that also, we tried with antigen phenotype match bloods also. So that was also, IAT was positive. Enzyme treatment reaction with enzyme treatment cell was also positive. All 11 cell panels, 18 cell panels, every type of cell panel was also giving positive reaction. But that also proved that there is some antibody which is against high frequency, and everywhere strength remains same. It is 3+ or 4+ strength. That is the more towards the high frequency antibody against high frequency antigen. So after that, so we could not find out the specificity. Only the after investigation of New York Blood Center and DNA analysis, because in our country we don't have, unfortunately, we don't have such a rare cells also available. We don't have that directory also available in the country currently. They are trying to, our National Institute of Hematology, Immunohematology is trying to maintain now rare cell directory, but till now we don't have detailed inventory of red cells rare cell panel. So that led to the difficulty for finding more compatible or conclusion type of thing, ki what could be the possible thing. And at the same time, it was difficult for us to manage the blood transfusion also. But when we sent the sample, this New York Blood Center, they tried over more 5,000 homozygous genetic variants, and with the less than frequency of 0.0001% tried with this rare phenotype. And after this filtering and a rare variant with two base pair deletion, which leads to the frame shift and premature stop codon generation. And this leads to the mutation. This mutation leads to the development of EMM negative blood group system. So this is about my story and my patient. Uh, but unfortunately, that is I've told you I could not. The patient ultimately doesn't need transfusion, and patient till the last minute he was well treated, well managed, but suddenly on one day he collapsed in the night and we lost him. This is the case history of my side. This type of cases should be reported very frequently. They should be presented on a scientific program. That is my take. And we should have a better directory of such kind of patients where having rare blood group. So this situation doesn't happen with anyone else also. And we need a good genetic laboratory in India to do DNA analysis of blood grouping at least. Blood group genotype laboratory is required in India currently.